Welcome back to our Let's Talk Oral Health Expert Series for the fourth and final episode of this year. In previous episodes, we have been exploring a 360-degree strategy to support prevention of periodontal and peri-implant diseases, talking about behavioral change, general health and the oral microbiome. If you would like to watch one of those episodes, you will find them on this YouTube channel in our Let's Talk Oral Health playlist. And once you're there, don't forget, subscribe and give the video a like. So today's video will conclude the series by discussing arguably the strongest preventative approach, mechanical plaque removal. And to do so, we have a very special guest in our studio. So without further ado, let's get started. So today we are joined by a friend of the show, Professor Filippo Graziani. Hello Filippo, welcome.
Hi. Thank you.
Filippo is a full professor of periodontology at the University of Pisa, Italy, where he coordinated the subunit in periodontology, halitosis and periodontal medicine. He's also a visiting professor in periodontology at the Interdental Institute, University College of London, and an honorary professor at the Faculty of Dentistry in Hong Kong. So again, welcome Filippo, it's good to see you. How are you doing?
Well, I'm very well and thank you for having me here. I'm very happy to be here.
We are also very pleased and very honored. So today we're going to talk about mechanical plaque control. And I think as a start, it's very important that we know what we are talking about when we're talking about plaque. So when we talk about plaque development, plaque accumulation, could you maybe give us some insight into the properties of plaque? What is actually happening on a biological level? Where does it accumulate? Are there some risky areas in the oral cavity that we need to pay special attention to? Could you maybe enlighten us on that topic?
Well, yes, of course. I mean, plaque, and it's a biofilm, as you might know, and I'm sure all the people that is watching this this show actually is very well aware. And biofilm are a puzzling and very complex structure. First of all, they are structures that are really made to survive. It's a clever organization that allows bacteria to survive and to strive and be successful. But we do need biofilms. We are surrounded by biofilms. We have them in our gastrointestinal areas, and in fact we call them intestinal flora, and it's a place where actually bugs are welcome, apparently. If you look at commercials, for example, for yogurts, you'll see that they are very well known. But we never say oral flora. We have a sort of a bias, a tendency, we as professionals of the oral cavity, to think that any bacterial accumulation is detrimental per se. But in fact, we need bacteria. We need bacteria to live, we need bacteria to think, we need bacteria to taste. They cover many aspects. The problem, in fact, doesn't come with plaque. The problem comes when there is a dysbiosis of plaque. It comes when there is some shift in the population, in the internal composition of plaque, towards some specific bacteria. Usually we're talking about strictly anaerobic gram-negative bacteria that actually are strictly linked with the inflammation of the tissues. But bacteria per se and plaque per se is not necessarily negative things. In fact, as I said, we need bacteria. Just think about how bad is the word sterile. Sterile is really a tremendous word. We are really made to be contaminated, not just by bacteria, but ideas and people. So, in a way, our oral cavity allows more accumulation because, of course, it's a secluded area with different tension of oxygen, different light, different temperature, and especially different humidity. So this allows bacteria to grow even faster than compared, for example, other areas such as the skin. But as you mentioned, the risky areas, it is very clear that there are some anthrax, there are some overhangs that would tend to accumulate even more. And classically, I would say the interdental areas and, for example, restorations or areas where you have crowding, these are areas where plaque tend to grow even more. So what is happening, and please do stop me if you need, because otherwise I will keep talking for hours. But
that's why we're here.
but really what is happening is that when you do have some sort of accumulation, and some bacteria tends to develop even more, tissues would react with inflammation. And when there is inflammation in a very peculiar way, that will influence bacterial population as well. And it's a vicious circle, because the more inflamed you are, the more some specific type of bacteria will grow, and the more they will grow, the more inflammation will determine. And to give you an idea, this is very different from where we started. In the 60s and the 70s, the idea of bacteria as a sort of a primum link of the disease.
The only cause.
The only cause. So the disease was infective, so we had lots of fight towards plaque, a lot of research on antimicrobials, for example. But that was very clear. You need to have bags to have inflammation.
Yes.
But now it is really not that clear. I mean, they're more talking to each other. I'll make an example. A few years ago, we released a trial that was based on nutraceutics. So the adjunctive effect, for example, of kiwi fruit on people with periodontitis. Yep. It's an infamous study because all the friends in the research tease me for that, but it's a different story. But what we learned that in the first 2 months in which we didn't do any treatment whatsoever, we just simply gave 2 kiwis per day to the patient, we saw that there was a reduction of inflammation that was expected because kiwi has so much vitamin C, so that was something expected. But even plaque decreased significantly. That means that even without doing anything to the plaque decreased, mechanically, yes indeed, plaque decreased because there was less inflammation. So there is a continuous talk between inflammation and plaque accumulation.
And is there, I mean, everybody develops a certain amount of inflammation when they're exposed to plaque. I mean, it's a normal, as you mentioned, an interaction between the host immune response and the plaque. Is there an explanation why some patients go into this vicious cycle of inflammatory processes, exaggerating each other over and over again, while other patients maybe remain stable once they have developed gingivitis, but they don't progress into periodontitis? Is there maybe a reason for that? Is it?
Well, inflammation is a good thing. We need to start to think. Inflammation is a good thing, it's something that we need. In fact, the bacterial accumulation would determine inflammation to anyone. This is what we know classically, but it is true. Then, of course, inflammation would manifest itself differently according to the type of population, but inflammation will be present for anyone, at least histologically, so to speak. The issue why, despite we all have plaque accumulation, because apart a very minority of periodontists and dental hygienists out there, the majority of the population, well, not even them, and I can tell you because I measured plaque level even to colleagues all my life, but let's say apart a minority of population, the majority of the people will actually have very high level of plaque.
Exactly.
Yet, the disease is widespread, but usually doesn't really affect more than the 50% of the population on the adult level, on, let's say between 30 and 40, 50 years old of age. So how come that everybody has the enemy, but only 1 out of 2 loses attachment and loses bone? The issue is related, in fact, to inflammation per se. It is correct. It is linked to the susceptibility of getting more inflamed. Basically, there are people, for some specific reason, then if you want, we can even discuss, who tend to inflammate more, to create more inflammation. Now, because the gum tissues are strictly packed, and there are really layers and layers of collagen fibers, and it's a lasagna of collagen fibers. And the only way inflammation can find the space is to destroy itself with some specific mechanism, the collagen and the lasagna, so to speak. So the people that would tend to inflammate more will have to reduce the amount of collagen and the amount of gingiva in order to create a space for the inflammatory infiltrate.
Right.
So what is that leads some people to develop this hyper-responsive, this redundant inflammation? Well, this susceptibility, it's actually due to many aspects. Clinically, this is my clinical view, and of course I don't have anything, no one really has scientific data on this, but I believe that there is never a single cause for an enhanced susceptibility. It's really a mix of many different possible effects, but usually there is surely a genetic component that is very strong, for example, in the cases of the young population and some specific type of disease with some specific patterns, for example. But it is not just about genetics. and we should not even make confusion between genetics and familiarity. The disease has some sort of familial cluster which might not be due only to genetics, because when we live in family together, we drink from the same glasses, we eat from the same fork, and so forth. So we live in the same bacterial context. But I think that is also linked very much to smoking, most importantly, but also all the metabolic status of the subject, not just, and I'm not just referring to the glycemic level of the patient, but also the cholesterol level, the overall inflammatory status of the patient. And then one of the very important cause, of course, let alone some systemic diseases, but one of the most important cause is the stress level. Stress has a tremendous impact on the oral cavity.
This is super fascinating, and for those who are watching, we also have separate episodes on, for example, the microbiome, the effect of the biofilm. We will also have an episode on the systemic health and how you can leverage systemic health to reduce the risk for periodontitis and help to prevent periodontitis. So if you're more interested to go in depth into those risk factors and topics, feel free to go to our YouTube channel and watch out those videos in the same playlist. But it's super insightful to see these massive effects of plaque, but especially the interaction with the host and the host immune system. That's really the key. You mentioned about how systemic health, systemic diseases, how lifestyle can influence your susceptibility to periodontitis. It's also maybe interesting to mention that there's also the other way around. So the plaque, the bacteria in your mouth, can also have systemic consequences. Could you maybe share a bit insight into that direction of the relationship?
Sure, and you know, I just want to say that this story, the funny bit that we are the only ones surprised about this. You know, we keep saying within our field, and you know what? But the oral cavity also affects systemic issues. But the oral cavity is systemic. The body is just one. And if you talk to any doctors with the capital D, but even to patients, would never even hesitate to think about that.
That's a good point.
We did a study that was many years ago, 10 years ago, when I was 12. And when we simply asked our patient, do you think that what you have in your mouth will actually affect the body? And the 89% said that for sure, that there was a link. Back then there was also another study that did ask the same questions to dentists, and not even the 60% of the dentists thought that the oral cavity would influence the body. So that means that the patient had a more holistic perception of health more than the dentists themselves, because we are very tremendous specialists. You know, we just work on a tiny bit of our body, and sometimes we might tend to forget.
Yes. Yeah.
But making this preamble very short, I mean, the point is that the inflammation and the bacterial accumulation that we have in the mouth would affect the body in an important level. Just to make it clear, at the moment, periodontitis is associated with 57 systemic diseases,
right, yes.
Which does not mean that periodontitis causes any of those, but it doesn't mean not even the opposite. It might be that there might be some causal link, but we still don't know. But surely there is an association. And the association is resting on some specific aspects. The reason why, for example, by having periodontitis, you might be proner to have atherosclerotic disease or diabetes, is really linked to some specific mechanism. First of all, even if bacteria do not normally infect the tissues, I mean, periodontitis is not an infective disease, they don't infect the gum, but there is some passage of bacteria. And this bacteria actually would go in the bloodstream. We know this from many evidence, from the biopsy from carotid atherotomatoous plaque up to some other studies on bacteremia, that bacteria would enter in the bloodstream. And we also know that if you are healthy from a gingival standpoint, or if you have gingivitis, when you go to the dentist and you get, for example, a dental cleaning, you surely have some passage of bacteria in the blood, which doesn't matter. We have so many mechanisms. If you remember the book of pathology, which is as tall as this, at least in my generation, we still used to have books, but we are really a war machine. I mean, our human body has so many mechanisms. So every time that you shave, if you have menstruation, if you have fevers, there are continuous passages of bacteria in the blood, and it is not a problem. We fight it and we win it. The problem comes when you have too many bacteria, and that is, of course, it's an infective septicemia, or when, for example, these bacteria are chronically elevated in the bloodstream. And for example, we know that if you are affected by periodontitis, 1 out of 5 times that you are chewing, your bacteria are going in the bloodstream. That implies that perhaps somebody with a severe periodontitis, stage 3 or stage 4, it may happen that has a sort of a daily passage of bacteria in the bloodstream. That might actually create some important alteration, which is in a way not just the presence of bacteria, some periopathogens, so to speak, like Porphyromonas gingivalis. Porphyromonas gingivalis is really a belligerent animal. It is really a bacteria that has so many clever capabilities in terms of to create issues and troubles everywhere that is incredible. It can infect single cells and getting out when inflammation goes down. I mean, it is really potent and has some important effect on myocardial cell as well as endothelial cells. But I think what is important is the fact that all this bacterial release would determine also some local inflammation, which we believe creates a sort of a resonance mechanism of the whole systemic inflammation. For example, if I have my local gingiva that is inflamed, that would determine lots of production of interleukin-6. This interleukin-6 would spill over, would go in the bloodstream, and would reach the liver. And at the liver level, there would be a production, for example, just to quote one, which is very famous in research, of C-reactive protein. CRP is an opsonin. Maybe you might remember that opsonin are these molecules that would bind, for example, to bacteria or some pathological agents so that the antibodies can actually recognize it and attack. So C-reactive protein is enhanced through inflammation, and in periodontitis, people with periodontitis tend to have higher level of C-reactive protein compared to people identical without periodontitis. Why this is a problem? It is a problem because when you are chronically inflamed, even at a lower level, that is actually associated with a higher tendency to develop an enormous amount of different type of systemic diseases. In fact, an elevation of systemic inflammation is clearly an indicator of future cardiovascular risk events. This is particularly true when you search for C-reactive protein at the high sensitive level, not the big one, but the one that you can find with a test that is extremely sensitive. And in that case, you can clearly stratify people according to the risk for cardiovascular diseases. What happens when you have periodontitis that you would tend to have higher level of this CRP that would put you already in a category of enhanced risk, for example, of cardiovascular diseases. So what is happening, to sum up, is that when you have a local inflammation, our body is so intelligent that it would back it up with a systemic inflammation. But this systemic inflammation would not solve itself and per se can link to other disease. So the presence of, for example, periodontitis can actually enhance the risk of developing.
And taking away the local inflammation can also help contribute to alleviating the body from systemic inflammation.
Massively, yes.
I think that's very interesting. Very interesting. You mentioned the association with cardio. At Sansar, we also did a recent study on the effects of. Now we're talking about professional cleaning, right? So really under the supervision of a periodontist, reducing the inflammation. However, we also did some recent research on home care, 3 times per day interdental cleaning. What is the effect on systemic health when you look at blood sugar levels? Comparing the 2 groups, one group who did it 3 times per day, the other group who did not perform interdental cleaning 3 times per day, and you really saw a difference in glucose levels fluctuating over the day, with the group cleaning interdentally more frequent, showing better HbA1c value, so better blood glucose control. I mean, that fully supports your story of...
Yeah, that doesn't come as a surprise. In fact, we published just recently a paper on JCP, on Journal of Clinical Periodontology, a few months ago, in which we analyzed people with gingivitis, and that was the first time that we were looking at systemic effects of gingivitis. And you could clearly see that even in gingivitis patient, we had to take a very large sample. We're talking about 140 patients, otherwise you would not notice. But removing local inflammation, even when it is not associated with periodontitis, determine a reduction of systemic inflammation. So every time that you touch a local inflammation, the body will respond because everything is linked. In periodontitis, because the amount of inflammation is so huge, the effects are so important that actually would also determine effect on, for example, glycemic control. Now, classically, we know that treating periodontitis would actually improve glycated hemoglobin to an extent that is the same extent of, for example, a second hypoglycemic drugs. But also we have indirect evidence that improvement of oral hygiene control would actually be beneficial for your cardiovascular health. So there is no discussion that within the frame of holistically treat somebody with a chronicity, oral health should be endorsed.
Yeah, I mean we don't need more rationale for mechanical plaque control. I mean, we now see it's really about removing the inflammation on a local level, and you even have systemic effects even on top of what you achieve locally in the mouth. So I think it's putting perfectly in context why we need mechanical plaque control. And with that, we have reached the end of part 1 of our conversation with Professor Graziani, laying the groundwork of why mechanical plaque control is crucial for the prevention of periodontal and peri-implant diseases. We discussed the role of plaque in health and disease and its interaction with the host immune system. If you found this interesting and would like to know more about the most optimal ways to support plaque control, check out part 2 of this episode. Simply follow the link that is now visible on your video screen or check out the description below. Don't forget to like and subscribe, and we'll see each other soon. This was Let's Talk Oral Health by Sunstar. Thank you for watching. Goodbye.